From the Columbia Cardiogenetics Clinic, a change in variant classification leads to a change in management. The role of cardiogenetics in everyday cardiology practice, a case series. Presented by Jessica Hennessey, MD, PhD, Assistant Professor of Medicine, and Natalie Lippa, MS, CGC, Assistant Professor in Genetic Counseling.
Let's dive into our next case titled Things Change. So this is a patient. He's a currently 54-year-old man when I met him with Poland syndrome, which is a congenital sort of loss of one portion of the body, like the breast tissue, and the left arm is shorter, atrial fibrillation, and a non-ischemic cardiomyopathy with an EF that really varied throughout his course from anywhere from 25 to 50%, depending on that. And it was first really noticed to be reduced around age 28, but has varied significantly over the years, as I said. They did note that some of his reduced ejection fraction was related to when he was an AFib, so we sort of blamed that, called it an AFib-associated cardiomyopathy, rapid rates, but it wasn't always that way. And so here's his ECG for completeness. Nothing that's really jumps out at you at all here. Normal intervals. The things we're looking at for cardiomyopathy in a young person on the ECG in particular are really conduction disease and ectopy are the major things, along with other evidence for ARVC. And nothing really jumps out at you here as suggestive of some sort of a cardiomyopathy, inherited cardiomyopathy in reality. But given his clinical history, his young age of onset, genetic testing was performed. And when we did it, we did a full arrhythmia and cardiomyopathy panel. And the reason that we did that is really twofold, I would say. One is at this time, Invitae was offering effectively free testing with this large panel to everyone at Columbia as their way of kind of getting in, is the way I would say it. But also, there are a few genes, not tons, that are known to be causative for AFib, and he did have a AFib family history. And so for those two reasons, it was reasonable to send that full panel. And when we did, we got two variants of uncertain significance. So one, an AGL, which is a glycogen storage enzyme. And then the second one you'll see at the bottom was in TNNT2, or the cardiac troponin T. And they're both variants of uncertain significance, and they're both heterozygous. So in reality, we didn't change our clinical management at all for this patient at this time. So, but let's dive into troponin, the cardiac troponin, for a minute here, just beforehand. So it's associated with dilated and hypertrophic cardiomyopathy. What's interesting about it is that it's typically a milder structural phenotype. So you're not going to see this massive dilation, the sort of the obvious stuff on your echo, the test that we're getting all the time. And more importantly, the risk of arrhythmia is not really directly related to the structural findings. And so you can have a relatively structural heart with one of these mutations and still have an arrhythmia. And there are sort of these hotspot, people use different words, and I get it, regions that correlate with worse arrhythmia phenotypes. And you can see in this paper above, the lower on this graph is worse, basically, is the point. And in our patient, he fit into the green region. So it's I thought this was a weird graph, but the graph is freedom from sudden cardiac death. So lower means less freedom from sudden cardiac death, meaning you have sudden cardiac death. So he's in the green portion there, which is suggestive that there is some risk of sudden cardiac death with mutations in this region in particular. This guy has not been validated as necessarily pathogenic, but if it were pathogenic, he would have a higher risk. So then we get an email this past year saying there's been a change in your patient's variant classification. And in fact, his troponin T2, his cardiac troponin T mutation actually has now been changed to pathogenic. So what do we do about that? How did it happen? Sort of, the two questions I always ask in these settings are, wait, how did this all of a sudden change? And now what the heck do I do about it? So Natalie, why don't you explain a little bit about how these things actually change?
Right. So I think the first step is to kind of think about the evolution of sequent variance interpretation guidelines. They were first written in 2015 by the ACMG, the American College of Medical Genetics, and the Association for Molecular Pathology. And this was really to standardize variant classification and interpretation so that people started to use the same terms like likely pathogenic, variant of unknown significance, things like that. Since that time, ClinGen has started taking over to modify the different guidelines within these original guidelines, really to make them stronger. And every so often, they'll publish new modifications, and that could change classifications of variants that have already been reported. So overall, this is like a points-based system where a variant can get different amounts of points related to how pathogenic it might be or how benign it might be. So a pathogenic variant might get more points if it's de novo, if it's previously been reported to cause disease, if it's rare, not found in NOMAD. And on the flip side, a variant gets points to how benign it is. So if it's found in NOMAD at a very high rate, or if functional evidence has proven that it's not disease causing, or there's no impact on protein function. And so for this particular variant, the two main reasons it was upgraded was because the internal lab Invitae had used advanced modeling, in silico modeling, that showed that the mutation really disrupts the TNNT2 function. But then additionally, within their internal system, they came across more patients with a similar presentation who had the exact same variant. And at the same time, when you look in ClinVar, you could see that this variant was classified pathogenic by other labs, and the same amino acid site was also being classified as pathogenic by other labs as well. So really, overall, it became clear that this variant was indeed disease-causing.
Okay, so we answered the why did it happen? So now what do we do about it? So as you remember what I said, pathogenic mutations in this region do portend a higher risk of sudden cardiac death. And so we ultimately changed our plan and recommended a primary prevention ICD for this patient, which was placed recently. Additionally, what do we do about the family, right? I actually kind of equate this one to similar to Lamin. Lamin's the common one that we all kind of know about. It's on the board exam and everything, where you know that having this genetic mutation does lead to a high risk of sudden cardiac death. This gene's not that far off from it. And so rather than just moving towards clinical screening, we actually now are recommending true genetic screening for his family members to ensure that if they are at higher risk of sudden cardiac death, we're taking appropriate precautions for them.
This was brought to you by the Center for Precision Medicine and Genomics at Columbia. This has been an internal medicine genetics case study.